السلام عليكم ورحمة الله وبركاته. مساء الخير مشاهدينا الكرام في أولى محاضرات فن الاستذكار التي نهدف من خلالها تبسيط وتسهيل أشهر المواضيع الطبية التي يدرسها جميع طلبة التخصصات الصحية، وسيتم استقبال جميع الأسئلة بعد الانتهاء من المحاضرة. معكم وجدان النهدي. نرحب بدكتور إيهاب سليمان، استشاري أمراض القلب في مدينة الملك عبد العزيز الطبية في الحرس الوطني بالرياض. أهلا فيك دكتور، وشكرا جدا لقبولك الدعوة.
جزاكم الله كل خير وبارك الله فيكم.
دكتور تسمعني؟
Yes, I hear you very well. Okay.
تفضل المايك عندك دكتور.
Okay. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. It is my pleasure today to talk about approach to chest pain. This is November 2020, the 5th of November. My name is Ihab Suleiman. I am a consultant cardiologist at National Guard Hospital in Riyadh, King Abdulaziz Cardiac Center. So the first thing we need to know is this simple photo about your approach to chest pain. The most important thing when you evaluate the chest pain is to take the history of the chest pain. And sometimes there are certain symptoms make you suspect that the chest pain is quite serious, especially if it was of a very sudden onset, the pain is severe, the chest pain is associated with collapse or syncope, the chest pain is on exercise, and the chest pain is so much severe that the patient is afraid or scared from death, and there is also associated breathlessness and vomiting. So history of chest pain is very important. On exam, you need to note certain parameters that will help you to reach a conclusion about the etiology and the differential diagnosis of chest pain. So the signs that suggest serious cause of chest pain include tachypnea, sweating, cyanosis, pulmonary edema, pleural or pericardial rub, hypotension, or in other words, systolic blood pressure less than 90 millimeters of mercury, or in other words, blood pressure 40 millimeters of mercury less systolic than the previous reading of systolic blood pressure. Absent pulses, anemia, tachycardia, and raised JVP. And your diagnostic approach should include 3 categories. The chest pain is cardiovascular or very serious, like aortic dissection in the middle row here, you can see it, or pulmonary embolism or pancreatitis, or the chest pain is due to acute coronary syndrome. Other causes of chest pain may be of less serious severity, are esophageal spasm, gastroesophageal reflux, gallbladder disease, and musculoskeletal pain. So there are a lot of variety of causes of chest pain, but the most important thing probably are aortic dissection, pulmonary embolism, and myocardial infarction. Always we need an ECG, always we need a chest X-ray, and always we need a cardiac enzymes. And the important question we should ask always, if the patient is well or unwell, because if he is unwell, then you need extra help. Then you might need to take the patient immediately to the cath lab or to the operating room. If the patient is in shock, then you might need to call the cardiac ICU staff or the medical cardiac ICU staff. If the patient is in severe pain, because your priority is to relieve the pain, or if the patient is in need of immediate resuscitation. So as we have told you, the differential diagnosis of chest pain could be wide, long, and you can differentiate it or put it into systems together or into main categories. So you can, under the heading of cardiac, you can put myocardial infarction, pericarditis, myocarditis, aortic stenosis. Then you, under the heading of pulmonary, you can put pulmonary embolism, pneumothorax, acute chest syndrome, which complicate sickle cell anemia, asthma, and COPD. Under the heading of pleura, you can put pleuritis and pneumothorax. Under the heading of aorta, you can put two differential of aortic dissection or perforated aortic ulcer. And under the heading of chest wall, you can put costochondritis or musculoskeletal. Under the heading of esophagus causes of chest pain, you can put esophageal spasm or eosinophilic esophagitis or esophageal rupture or perforation or gastroesophageal reflux disease. And then miscellaneous could include mediastinitis or right upper quadrant pathology like in gallbladder disease. Those patients sometimes they have chest pain. Panic attack, we should not forget that panic attack can present with chest pain. So this is the widest differential of chest pain. What should we concentrate about when we evaluate a patient with chest pain in the emergency room or in the CCU or in the medical ward? The first thing that comes to our mind, especially I am a cardiologist, is acute coronary syndrome. And acute coronary syndrome comprises ST elevation myocardial infarction, non-ST elevation myocardial infarction, and unstable angina. Then we have acute aortic dissection type A. Then we have massive pulmonary embolism, pericardial tamponade, esophageal rupture, and tension pneumothorax. So these are the 6 causes. We call it the lethal causes of chest pain because they need prompt identification and prompt management. Acute coronary syndrome, the patient need to go to the cath lab immediately or on the next day. Acute aortic dissection type A, the patient need to be in the operating cardiac theater. Massive pulmonary embolism, once suspected, the patient need to be started on anticoagulation. Pericardial tamponade, if the cause is medical, the patient should receive precardiocentesis bedside as soon as possible. Esophageal rupture followed by severe mediastinitis, the patient should be given resuscitation, IV antibiotics, and IV fluids, inotropes, and also sent to the operating thoracic surgery theater. Tension pneumothorax need relief by any means available before you send the patient to any chest X-ray or any other investigation. The most important thing when you evaluate a patient with chest pain is to ask the patient to locate the patient either with his hand, with his finger, or with any method. Because if the patient is pointing to the pain with his hand or finger, this will differentiate between serious and less serious causes of chest pain. Usually, breaking chest pain and finger pointing chest pain is less serious than if the chest pain is involving large area of the thorax. So what differentiates typical cardiac chest pain like ischemia from non-cardiac or atypical chest pain? So for the typical chest pain, the one you can suspect myocardial ischemia, it is characterized by discomfort or pressure. Duration is more than 2 minutes. It is provoked on activity or in exercise. It radiates to the arms or jaw. and it has no relation with respiration or position. And sometimes it is received by rest and nitroglycerin, and sometimes it is experienced after marital life. Atypical or non-ischemic type of chest pain can be localized by one finger. The chest pain is either lasting for days or lasting for few seconds, and the patient could be reproduced easily by movement or by palpation. These are important causes. So when you evaluate a patient with chest pain, you need to ask the nurse for the most current set of vital signs on your arrival. You need to ask the nurse to get an EKG, which should be done and read within maximum of 10 minutes on arrival of the patient to the door of ER or to the door of the clinic. And you need to see the patient by yourself, assess and decide what to do next. And at bedside, you need to determine if the patient is stable or unstable, because unstable patient need from you more help and more consultation to other senior or other colleagues, and you need to decide when or where should the patient go. Is it a pulmonary embolism? The patient need to go for spiral CT. Is it aortic dissection type A? You need to call the cardiac surgeon to open the cardiac OR. Is it a ruptured esophagus? You need to call the thoracic surgery to open the cardiac, either cardiac OR or thoracic surgery OR, operating room. Or is it pulmonary embolism? Then you need to start your anticoagulation either by enoxaparin or by intravenous heparin and fractionated heparin. And please don't forget, when you see any patient in the hospital, when you finish the assessment, you need to document in the clinical notes that you are so and so resident or intern or attachment doctor or a consultant or an associate consultant. You called on this day at this time to see this gentleman or this lady, and you found such and such, and the patient differential diagnosis is so, and you decided to do an echo and cardiac CT and other evaluation. So you need to concentrate on your physical exams, on the tachycardia, hypotension. The hemodynamic parameters are important, and hypoxia. And the general look is very important because it can give you an idea about the patient stability. So let us take an example, an easy example of a 25-year-old lady who suddenly have chest pain, left-sided, and it was worse on breathing, and her blood pressure was 110/70, but her oxygen saturation is 89% on 2 liters, and the oxygen saturation was reported better on room air this morning. So there is clear oxy desatting in a young lady presenting with left-sided chest pain. Her general exam is showing that she's using her accessory muscle of respiration, and the rest of the exam, there is nothing of significance, but her laboratory markers showed that she has got elevated BMB, and her D dimer is positive. D dimer is very sensitive for pulmonary embolism. It is also very sensitive for other conditions, which include fibrinogen consumption, like deep vein thrombosis, like aortic dissection, and like sometimes even in acute coronary syndrome, it can be minor elevation. D dimer is also false positive in pregnancy and post-surgery. So post-surgery, you might find the D dimer anyhow is positive, and postpartum, you might find that the D dimer is positive. So D dimer, it is good when it is negative. D dimer still can be a good differentiating point between Whether it is negative, then you can exclude with some reliability pulmonary embolism. The ECG is clear, showing sinus tachycardia, and sinus tachycardia is the most common ECG finding of pulmonary embolism. The chest X-ray is important even if you suspect pulmonary embolism and the diagnosis is correct, because sometimes there are pneumonia, heart failure, other things that you need to exclude. And the chest X-ray in this example or in this scenario is normal. So you go, whenever you assess a patient with chest pain, you go through your long list of differential, and then you go to the modified Wells criteria, which will make pulmonary embolism scoring for you easy. So the patient had clinical symptoms of DVT, you get 3 points, and heart rate is more than 100. The patient is immobilized, like post-surgical or postpartum. If the patient has hemoptysis or the patient has malignancy, 20% of DVT or pulmonary embolism which occur in the elderly might be precipitated by malignancy. So malignancy, especially adenocarcinoma of the gastrointestinal tract, are important causes of pulmonary embolism or atherothrombosis in general. So you do your score model for pulmonary embolism, and for this lady, her interpretation of her symptomatology and presentation is going with a moderate to high risk. Then you need to go for your next movement. You need to obtain either D-dimer was also obtained, but you need to do an arterial blood gas to see the elevated A gradient. You need to do an ECG maybe, and it is already done. You need to do a VQ scan if the patient creatinine is high and you cannot do a CT scan. Sometimes you do a leg ultrasound to rule out or rule in deep vein thrombosis. But the most important investigation is CT pulmonary embolism protocol. What is written in the last of the slide is CT pulmonary embolism protocol. We call it sometimes spiral CT. We call it sometimes CT pulmonary angiography. So CT is the standard method of diagnosing of pulmonary embolism, and all the guidelines tell you if the patient is highly suspicious for pulmonary embolism, start anticoagulation and send the patient immediately to the CT scan to make the diagnosis certain. You don't need to wait for the D-dimer, or you don't wait for the Doppler ultrasound of the lower limbs. And CT scan has a very good specificity and sensitivity. Remember, a patient with pulmonary embolism or any other chest pain scenario presentation, you need to have a good IV line, and at least you should have more than one A line to monitor the patient well and to give the IV fluids, IV heparin, or to draw your blood evaluation. This is the same case. The patient went for a CT scan of the pulmonary artery, and this is main PA in the middle of your slide. You find the word or the letter mean pulmonary artery, and there is a saddle-shaped filling defect of massive pulmonary embolism or pulmonary thrombus, and this is diagnostic of pulmonary embolism, or we call it massive pulmonary embolism. And the patient, always when you have a massive pulmonary embolism, you need to consult with your cardiac surgeon or thoracic surgeon, because sometimes surgery might only be the hope for such patients. Sometimes you can call your interventional radiology. And alhamdulillah, in the Kingdom of Saudi Arabia, we have now a very good program of interventional radiology. Interventional radiology, they can put lines, they can put permacas, they can do biopsy. They can do also now pulmonary artery embolectomy by interventional radiology, and without the need for surgery. So you can have many options of management of massive pulmonary embolism other than your thrombolysis or your IV heparin. And remember, it is important to start the management when you suspect pulmonary embolism. So the management is by giving the patient oxygen, IV fluids, and consider fibrinolytic therapy or other form of anticoagulation. And this is important. This slide is showing that whenever you suspect pulmonary embolism, more than moderate suspicion, you should start your anticoagulation. And pulmonary embolism with hypotension, the patient should be considered for thrombolysis, and you should also consider the patient for catheter-based thrombectomy by your interventional radiology team in the hospital, or you can consider surgical thrombectomy. So you have three options of management of massive pulmonary embolism, especially those patients who are hemodynamically unstable. You can give the patient thrombolysis, and preferably you should admit the patient to the ICU over the night to be observed. And thrombolysis, there is 1% risk of intracranial bleed, and you need to exclude bleeding ulcer or any intracranial neoplasm or intracranial hemorrhage before you give your thrombolysis. And sometimes if the patient has prior intracranial bleed or he has intracranial aneurysm, thrombolysis will be out. You might need to consider the other two options of catheter-based thrombectomy or surgical thrombectomy, but it depends on your center experience and it depends on your hospital policy. And sometimes those patients with massive pulmonary embolism are admitted to ICU. Sometimes they are admitted to cardiology ICU, and sometimes they can go to the surgical cardiology ICU. So it depends from one hospital to the other. It depends on their policy, their guidelines, and their management pathway. Let us take another case of a patient with chest pain. So this is a 67-year-old gentleman. He has past medical history of hypertension, dyslipidemia, diabetes type 2, and he has also evidence of coronary artery disease. He had BCI in 2017, but he presents now with new chest pain. And his new chest pain is severe. It is 7 out of 10, and it is associated with nausea and diaphoresis. On his physical exam, he looks a little bit unwell with oxygen saturation 93%. And his physical exam is showing that the patient is unwell and diaphoretic, and he has a bilateral basal crepitation, and his troponin is the lower limit of normal or upper limit of borderline. And this is a patient in which the differential diagnosis could be wide for him. He could have anything. He could have acute MI, he could have pulmonary embolism, he could have tension pneumothorax, and he could have aortic dissection. So you need to keep your mind open, and you need to consider all the possibilities of chest pain. The patient had history of hypertension, so dissection could be a possibility. The patient had a history of BCI, so he could have another acute coronary syndrome. The patient is 67 years of age. He could have malignancy and pulmonary embolism. The patient is diabetic. He could have diabetic cardiomyopathy. The patient is having nausea and diaphoresis. He could have other abdominal condition like pancreatitis. So you need to keep your mind open-minded and to consider all the possibilities. And you need maybe to do more than once ECG, and you need to review the chest X-ray. You might need to do troponin, one set, another set, a third set, fourth set. Of course, acute coronary syndrome seems to be the most likely diagnosis. When you do your ECG, it makes your life easier, because if you look to the ECG, there is clear ST depression on the lateral leads. So the patient is having, and there is also ST depression on lead 1 and lead AVL, and there is also sinus tachycardia. So the patient ECG is abnormal and can easily go with acute coronary syndrome or with recurrence of acute coronary syndrome, but the patient has also, and there is also LVH, left ventricular hypertrophy changes. So still you need to keep other diagnoses differential in your mind, even if you consider acute coronary syndrome is the most likely diagnosis, as in this case. So you label this case as unstable angina, front/non-STEMI, because still your troponin I, the first set, was not elevated. And you need to look for serial of ECG. Of course, if there is ST elevation, that makes the diagnosis of ST elevation MI more easier. When there is ST depression or ST T wave changes, you need to diagnose the patient as non-ST elevation myocardial infarction. Remember, ECG is, the first ECG is only sensitive in 50% of cases of acute MI. That is why you might need to do a repetition of the ECG, and you might need to do a serial of ECG every 3 hours, every 6 hours, or when the patient is having any chest pain. So there is no rule how many times you do the ECG for a patient coming to the ER with chest pain like acute coronary syndrome, especially if the first ECG does not show much. You need to repeat it whenever the patient experiences chest pain. You need to repeat it maybe every 3 to 6 hours. You need maybe to repeat it whenever there is hemodynamic changes on the patient. So you should work up your mind well, and you should keep monitoring the patient in a good way. Remember, troponin is becoming now the standard for diagnosis of acute coronary syndrome. Either cardiac troponin I or cardiac troponin T is becoming the standard cardiac biomarkers. We no longer depend on CBK or CBK-MB or LDH or AST or other cardiac markers. The only marker we use is cardiac troponin I and cardiac troponin T. And the next step in this patient is, of course, to call your cath lab consultant to see if the patient can go to the cath lab on the same presentation hour from the ER, or to wait in the morning. If the patient is having acute STEMI, you need to go to the cath lab within 60 minutes from the time of ECG, or within 90 minutes from his arrival to the door of ER. And this is another ECG. You can find that there is also a deep T wave inversion, and this can also suggest like subendocardial LAD infarction. This diagram tells you how medicine has progressed over the last 50 years or 70 years. And according to the fourth definition of myocardial infarction in 2018, we no longer depend on cardiac CBK, we only depend on cardiac troponin. So this slide give you idea about the new universal definition of myocardial infarction. And we are dividing myocardial infarction into 5 types. And there is new section of myocardial infarction like Takotsubo syndrome, Minoka, and chronic kidney disease coming with MI or positive troponin I and atrial fibrillation. And these are the way the definition of myocardial infarction has been set, that the most important thing for myocardial infarctions, the patient should have symptoms of myocardial ischemia, and this should be or should not be accompanied by ischemic ECG changes. But the most important thing is the cardiac troponin. As you can find it, that there should be criteria for myocardial injury, and the patient should have elevated cardiac troponin according to his age or to his sex, male or female. There is certain criteria, and we should follow that criteria. But remember, cardiac troponin I or cardiac troponin T can also get positive with other cardiac condition or non-cardiac condition. But if it is very positive, it can only suggest myocardial infarction. So the criteria for type 1 MI is a patient who comes from home with chest pain and his cardiac troponin I is positive, as in the universal definition of myocardial infarction in 2018. So we have now two types of myocardial infarction. We have type 1, and this is a common MCQ question in the exam with the STEMI, especially in STEMI cases or non-STEMI cases. So in acute ST elevation myocardial infarction, we have plaque rupture and erosion of the plaque with a thrombus that actually occlude the whole lumen of the coronary artery. And then we have a plaque rupture or erosion with non-occlusive thrombus, and this is the pathophysiology of non-STEMI. So the first shape is regarding the pathophysiology of ST elevation MI, and the second one is about non-ST elevation myocardial infarction. And this is another patient who has got inferior myocardial infarction, and he has got severe bradycardia. Let us count the heart rate of this patient. If you can see my ECG, there is ST elevation in lead 2, lead 3, and AVF, and this makes the diagnosis of acute inferior ST elevation MI likely, but the patient is very bradycardic, and you should avoid beta blockers giving to this patient because you might need to give him atropine, IV fluids, if you suspect RV infarction, and to send him to the cath lab. So all other than beta blockers, nitroglycerin are contraindicated in patients with inferior MI and RV infarction, and also patients who are using phosphodiesterase type 5 inhibitors like Viagra, Cialis, sildenafil, tadalafil. Nitroglycerin are contraindicated because this can lead to hypotension. Let us move to another case, case 3. So he is a patient who had a history of type 2 diabetes, non-alcoholic steatohepatitis. He has an old history of non-ST elevation MI, but he presented with also hypertension and very severe retrosternal chest pain. He tells you his chest pain is different from the pain of the prior MI. And this chest pain radiates to the neck. So when there is a chest pain that radiates to the neck, and it is a very severe, actually dissection or aortic dissection chest pain is very severe, that sometimes when the patient comes to the ER, they start screaming from pain, and they need to have painkillers to sedate them. So you need to be alerted to such type of chest pain that is very severe or makes the patient scream from chest pain, or the patient tell you, if he is a non-cardiac patient, that his chest pain is actually different from the prior MI chest pain. So we need to be very, very critical about such a patient with chest pain. His oxygen saturation is not dropping, and he is tachycardic. But the most important thing is his chest X-ray. The chest X-ray is showing wide mediastinum. The area around the aortic aorta is very wide, unexpectedly, and this should raise the suspicion of aortic dissection. And this is the way you can appreciate the aorta or the normal mediastinum. So this patient X-ray is quite widened, and you should suspect aortic dissection. And aortic dissection, CT scan is very important, and because it can show you the dissection, as in your left, on the left of your slide, there is dissection with the yellow arrow to the descending aorta. In the middle of your slide, there is a black arrow pointing towards the dissection of the ascending aorta. On your right of the slide, there is a transesophageal echo of the aorta. So you can diagnose aortic dissection either by a CT scan of the aorta. You can also depend on a transesophageal echo, but most of the people prefer CT scan or CT aorta or CT angiography as the first line. What are the risk factors of thoracic aortic dissection? Hypertension, 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 hypertension. And remember, any procedure on the aorta or in the aortic valve can increase the susceptibility to dissection, and certain collagen disorders like Marfan syndrome and Ehlers-Danlos syndrome. Ehlers-Danlos syndrome, the most common severe type, not the most common, but the most severe form of Ehlers-Danlos is actually the vascular type of Ehlers-Danlos syndrome, which has a prevalence of 1 in 90,000. The patient can present at an earlier age with aortic dissection. So this is aortic dissection type A on your left of a slide, in which the ascending aorta is involved. And this is aortic dissection type B on the right of your slide, when the dissection starts after or distal to the origin of the left subclavian artery. Thoracic aortic dissection is divided into type A, and the patient needs to go for surgery, 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 surgery. And type B, the patient needs to be on beta blockers, preferably intravenously, by giving labetalol or nitroprusside or other form of any blood pressure lowering. And the patient should have, in either case, arterial line to measure and control the blood pressure. And this is how you can suspect aortic dissection. You can have a model and you can suspect. Remember, in aortic dissection, the D diameter is elevated. Let us go to case 4. This is a 53 years old male with chest pain, and he has EKG abnormality. And when you assess him, he tells you that this chest pain has been present for 2 days, but it is getting worse, and it is getting worse with breathing. So it has some atypical features. And he tells you he has like a viral upper respiratory tract infection. So this is a presentation of like acute viral pericarditis, relatively young person, and he has chest pain for a few days. He had a recent flu. Sometimes you don't find the history of flu, but the chest pain is associated or is affected by breathing. So it makes your suspicion for acute pericarditis likely. Your chest X-ray will be expected to be normal. Your physical exam will show some sinus tachycardia and some distress, but oxygen saturation will be normal. And this is the ECG showing diffuse ST segment elevation in most of the lead, as expected in a case of acute pericarditis. Remember, if you have any suspicion of myocardial infarction, take the patient to the cath lab. So when you suspect acute pericarditis confidently, and somebody else comes, or you became suspicion that the patient could have acute MI, please take the patient to the cath lab, because cathing a patient with acute pericarditis is not harmful, and the patient will not suffer serious consequences. So this is pericarditis. It is inflammation of the pericardial sac, and the patient need to be on anti-inflammatory drugs. And this is the etiology of pericarditis. the most common cause is viral. Sometimes uremia or renal failure can be a cause of acute pericarditis. And how you differentiate on this slide between acute pericarditis, acute MI, and early repolarization. And this is how you diagnose acute pericarditis. You should have 2 criteria out of 4 from up to date to diagnose acute pericarditis. And sometimes you need to admit the patient with pericarditis to the hospital, especially if they have high-risk features like fever, or they are having impending tamponade, or they are immunosuppressed, or they are not responding to medical management. And these are the medication list that you can use in cases of acute pericarditis. The dose of aspirin in acute pericarditis is different from the dose of aspirin in coronary artery disease, because aspirin as anti-inflammatory need a dose of 2 to 4 grams a day. Nowadays, we use colchicine, is more famous than other medication. Non-steroidal anti-inflammatory can be used, but they should be avoided in acute pericarditis post-MI. So case 5 is a patient who is having rheumatoid arthritis, and he has progressive shortness of breath, and he underwent thoracocentesis with removal of 1.5 liters of pleural fluid. And 2 hours after his procedure, he felt right-sided chest pain. This is his chest X-ray. You can see that on his right side, there is like pneumothorax. There is black shadow on the lower part of the chest X-ray, and it is more evident on the right lower part of his chest. So makes the diagnosis of pneumothorax likely. Pneumothorax, the management is by assessment of the patient and his vital status, and you need to put a drain if the pneumothorax is more than 3 centimeters, and if the patient is not responding to needle aspiration, you need to get the help of the thoracic surgeon on call. This is all I have to say today about approach and differential diagnosis of chest pain, and how you go through your differential diagnosis and management. Thank you very much. وآخر دعوانا أن الحمد لله رب العالمين. Thank you very much. The slides, you can get it through Wajdan al-Nahdi. She's a doctor from Jeddah. Thank you. I am ready now for any question if you would like to ask. So welcome to the question. So if you have, okay, if there is any question I could answer, I would rather speak rather than write, so I could answer any question. Okay.
إن شاء الله راح نستقبل الآن أسئلة.
Okay, if there is
اللي عنده أي سؤال يكتب في الكومنتس، إن شاء الله الدكتور جاوب عليها.
شكرا جزيلا، بارك الله فيكم. اوكي، جزاكم الله كل خير. Okay, thank you. Okay, thank you. شكرا. Thank you very much. Thank you. I agree with you. I think we should